Hi, and welcome back to the ProPA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into restrictive cardiomyopathy, the rarest of the cardiomyopathies. Unlike dilated or hypertrophic cardiomyopathy, restrictive cardiomyopathy is all about stiff ventricles that can't relax, leading to significant diastolic dysfunction. In this episode, we'll go over what restrictive cardiomyopathy is, who's at risk, how it presents, how to diagnose it, and what the management looks like. Plus, we'll break down some key clinical pearls and finish off with 2 case-based questions to reinforce your knowledge. Let's get started. Starting off with some basic pathophysiology, restrictive cardiomyopathy is all about diastolic dysfunction. The heart muscle becomes stiff and non-compliant, which means it doesn't relax properly during diastole, making it hard for the ventricles to fill with blood. Over time, this usually leads to right-sided heart failure symptoms, like jugular venous distension, peripheral edema, and ascites. The most common causes of restrictive cardiomyopathy include infiltrative diseases like amyloidosis and sarcoidosis, storage diseases like hemochromatosis, secondary causes from radiation or chemotherapy toxicity, and idiopathic causes when no clear etiology is found. However, amyloidosis is by far the most common cause, where misfolded proteins infiltrate the heart, making it stiff and non-compliant. Now, who is affected? Restrictive cardiomyopathy is relatively rare. It is only present in 5% of cardiomyopathy cases. The incidence and prevalence are etiology dependent, such as more common in elderly when due to amyloidosis and more common in Black women when due to sarcoidosis. It's also important to recognize that restrictive cardiomyopathy can be genetic, so if you have a younger patient with a family history of unexplained heart failure, it may be worth looking into. As far as clinical presentation, the key here is recognizing signs and symptoms of heart failure. Symptoms include dyspnea on exertion, fatigue, peripheral edema, and ascites. Patients may also present with jugular venous distension and Kussmaul's sign, which is a paradoxical rise in jugular venous pressure with inspiration. You'll also want to keep an eye out for signs of causative pathologies, such as bronze skin in hemochromatosis, carpal tunnel syndrome in amyloidosis, and respiratory symptoms in sarcoidosis. Regarding diagnosis, in patients who are suspected of having restrictive cardiomyopathy, the initial evaluation focuses on differentiating this from other cardiomyopathies and evaluating for potential secondary causes. All patients should have a focused history, echocardiography, electrocardiogram, if not already performed, chest imaging, and laboratory testing. The signs that characterize restrictive cardiomyopathy on echocardiogram is a normal or near normal left ventricular systolic function and cavity size, an abnormal diastolic function, and marked enlargement of one or both atria. This pattern warrants further testing for specific causes of restrictive cardiomyopathy. The electrocardiogram is typically abnormal, but nonspecific. It may include ST changes, conduction delays, and other arrhythmias. And a low voltage may be noted in amyloidosis. A chest X-ray should be obtained to determine severity of heart failure, as well as may show signs of sarcoidosis or radiation-induced restrictive cardiomyopathy. Labs are obtained to assess the severity of disease and evaluate for possible secondary causes. You would want to order a CBC, complete metabolic panel, troponin, B natriuretic peptide, iron studies, and monoclonal protein studies. And one last little note here is that a cardiac MRI can identify infiltrative diseases like amyloidosis or hemochromatosis. Now let's move on to the management. Treatment is aimed at managing heart failure and underlying secondary causes, such as amyloidosis, sarcoidosis, or hemochromatosis. Regardless of the etiology, the general management involves that of volume status with diuretics to reduce pulmonary and central venous congestion and management of end organ dysfunction. Given the progressive nature of most forms of restrictive cardiomyopathy, patients should be referred early for heart transplantation. Now let's talk about the prevention. While we can't always prevent restrictive cardiomyopathy, we can screen at-risk patients. You'll want to monitor patients with chronic inflammatory diseases or amyloidosis risk factors, assess for iron overload in hemochromatosis carriers, and optimize cardiovascular risk factors like hypertension and diabetes to prevent secondary cardiac dysfunction. Here are some clinical pearls. Number 1. Restrictive cardiomyopathy equals stiff ventricles with diastolic dysfunction, but a normal or only mildly reduced ejection fraction. Number 2. Amyloidosis is the most common cause, and a low voltage EKG is a clue. Number 3. Differentiate from constrictive pericarditis. Restrictive cardiomyopathy has a normal pericardium, and not pericardial calcifications like in constrictive pericarditis. And number 4. Treatment is supportive. Manage the volume status and treat the underlying cause. Alright, let's practice some questions. Question 1. A 72-year-old man presents with progressive shortness of breath, bilateral leg swelling, and fatigue over the past 6 months. Physical exam reveals jugular venous distension, Kussmaul's sign, peripheral edema, and an S3 gallop. EKG shows low voltage and echocardiogram reveals biatrial enlargement with normal left ventricular function and diastolic dysfunction. Which of the following is the most likely diagnosis? Is it A. Dilated cardiomyopathy, B. Hypertrophic cardiomyopathy, C. Restrictive cardiomyopathy, or D. Constrictive pericarditis? I'll give you a couple of seconds. If you chose C. Restrictive cardiomyopathy, you are correct. The combination of right-sided heart failure, Kussmaul's sign, biatrial enlargement, and diastolic dysfunction with normal left ventricular systolic function strongly suggests restrictive cardiomyopathy, and low voltage on EKG is a clue of amyloidosis-related restrictive cardiomyopathy. Question 2. A 65-year-old woman with a history of hypertension and well-controlled type 2 diabetes presents with progressive shortness of breath, bilateral leg swelling, and fatigue over the past 6 months. She denies chest pain, orthopnea, or recent infections. Physical exam reveals jugular venous distension, bilateral pitting edema, and clear lung sounds. Laboratory results show normal troponin, B natriuretic peptide of 450, which is elevated, and normal renal function. EKG demonstrates low voltage and nonspecific ST segment and T wave changes. Which of the following is the best next step to evaluate the cause of her symptoms? Is it A. Echocardiogram, B. Chest X-ray, C. Cardiac MRI, or D. Complete blood count? If you chose A. Echocardiogram, you are correct. This patient presents with right-sided heart failure symptoms and low voltage on EKG, raising suspicion for restrictive cardiomyopathy, particularly due to an infiltrative disease like amyloidosis. Echocardiography is the best initial test because it can identify restrictive filling patterns, biatrial enlargement, and assess ejection fraction, which is typically preserved in restrictive cardiomyopathy. While a chest X-ray may show cardiomegaly or pulmonary congestion, it is not the best next test to determine the underlying cause. As far as cardiac MRI, this is a great next step if amyloidosis or sarcoidosis is suspected after an echocardiogram, but not the first-line test. And as far as a CBC, this is useful in systemic evaluation, but does not directly help diagnose cardiac dysfunction. Great job! And that's a wrap on restrictive cardiomyopathy. If you take anything from this episode, remember that restrictive cardiomyopathy involves diastolic heart failure with stiff ventricles and a normal or only mildly reduced ejection fraction. It's often caused by amyloidosis, sarcoidosis, or iron overload. And while treatment is limited, recognizing the condition early can help improve outcomes. If you enjoyed this episode, be sure to subscribe and check out our upcoming episodes on other cardiomyopathies. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.